Young gentleman lying comfortably is of normal average build, and there's been no discomfort in lying flat. There's been no scar mark and any other visible pulsations or JVP or visible apex beat present on inspection. Apart of that, on the patient was complaining of some tenderness on the left upper parasternal region, but it was not that much on palpation, but patient was complaining. So other than that, apex beat was palpable on fifth intercostal space, mid-clavicular line, about 9 centimeter away from the left lower parasternal region. Other than that, palpable thrill was present, which was actually located, which was actually started from the mid left parasternal region to the upper left parasternal region. Other than that, there's been no other remarkable finding on palpation. The JVP was not raised, there was no abdominal tenderness, and I could not appreciate any hepatomegaly as well. On auscultation, there's murmur. There was a murmur of grade 4/6 basically, and it was easily audible throughout the precordium. And the best audible points were the mid left parasternal region and upper left parasternal region. And the thrill was also best intensified over there. The murmur was radiating towards a suprasternal notch at that particular area. There was no radiation in the carotid or into the axilla or at the back. Other than that, the pulse was regular. There was no radioradial, radiofemoral delay, and the distal pulses were also palpable. Other than that, there is no remarkable finding.
So you are done with your findings. So there are two components of presentation when you're presenting in short cases. One is your comprehensive clinical finding, then ready for conclusion. Conclusion means your diagnosis and logical reasons for that diagnosis. Now let's first discuss about his presentation. Two, three things. It was good in terms that it was confident presentation. He wasn't shaky. But the sequence of things were not there. Have you told us about precordium symmetrical or bulging? No. So when you are asked to examine precordium, that means first I want to know, is the chest symmetrical or precordium is bulging? So that you can only see when you go to the potent and come to the level of patient there. Here, in spite, I haven't gone to there, but I can clearly see that this part is bulging as compared to this part. That indirectly tells that you are going to get something in precordium, because there is so much structural problem that the precordium is bulging. Then inspection of any other pulsations.
Yes.
Apex beat, suprasternal, epigastrum, intercostals, that need to be mentioned. If there are no other pulsations, then you can combine your inspection finding of inspection of that apex beat with palpation. But if there are other pulsations on inspection, then you need to mention. There are pulsations in suprasternal notch, epigastrium, and intercostal spaces. And apex beat is visible as well as palpable.
Yes.
And the distance of apex beat should be told not from lower sternal border, from midline. Itne centimeter from the midline. And when you are describing apex beat, it should be clear landmark in relation to vertical and longitudinal plane. That apex beat is in this intercostal space that much centimeter from the midline. So that gives us both vertical and longitudinal plane of apex beat. Specific. A number of times people come, apex beat is they are just lateral to mid clavicle.
No.
How much lateral to mid clavicle or anterior axillary? Or displace a mid axillary, you can say it's a mid axillary. Then second, apex beat character. I would like to know. If you are unable to pick character, leave. Just if we have clearly identified the character, is it forceful sustained, forceful non-sustained, tapping, whatever kind of apex beat you have, and this should be sequence. Ideally, what we used to do, we make a algorithm in a way written formats, because most of time you are examining either valvular or congenital. So you got these things. So make a pre-format to present जो मैंने आपको बताया, symmetry, inspectory finding, palpatory finding, starting with apex beat. Then you haven't told us about parasternal heave.
Sir,
There was a thrill.
Yes.
If precordium is bulging, I expect parasternal heave in this patient.
It was present, sir.
There must be RV heave. That was omitted because आप उनको logically जोड़ नहीं रहे चीज़ों को. You have to give, और ये आप पहले ही सवाल पे क्लीन बोल्ड हो जाएंगे और फिर मैं आपको दिखाऊंगा ये रही पैरास्टर्नल हीव. क्योंकि प्रीकॉर्डियम बल्जिंग है, आरवीओटी ऑब्स्ट्रक्शन है, तो पैरास्टर्नल हीव तो होनी ही होगी. Ideally you should be showing this to your examiner just like this, that this hand has these fingers are for apex beat and palpable sound. This portion is to look for thrills and this is for parasternal heave. And मिट करना है और ये इसको मेजर करना है. फिर आपका हाथ यहाँ पड़ा हुआ है तो ये पैरास्टर्नल हीव देखनी है ये.
Yes.
और ज़रा सा उसमें गड़बड़ है तो आप कह दें सांस रोक ले, बहुत ज़बरदस्त पैरास्टर्नल. फिर ये इस एरिया से यू हैव टू लुक फॉर थ्रिल्स. थ्रिल, that's the way to cover your palpation. Apex beat, any parasternal heave, any palpable sound, any thrill in any areas. If they are not there, just say, describe apex beat and there are no palpable sounds or thrill anywhere else in precordium. These negative findings should be described as well. So you have covered inspection, you have covered palpation, now you are coming to auscultation. Auscultation, we started with just directly murmur. That's the wrong way of starting auscultation. Heart sounds are audible in all four areas with normal intensity. That's the opening sentence of auscultation. If anything wrong with the intensity of heart sound, then mention that. So that's why what I'm saying, make a pre-format that how you're going to present things. यकीन मानिए आपकी प्रेजेंटेशन जो वो 2 मिनट की होती है ना, आधा वाइवा आप वहाँ पे कर चुके होते हैं. If you present your findings in a sequence, logically, positive and negative findings, so examiner की sympathy आपके साथ हो चुकी होती है और आपने examine भी अच्छे तरीके से किया. वो हम बाद में डिस्कस कर लेंगे कि how to examine step wise, जो शो करता है आपकी प्रोफेशनल एक्सेलेंस कि आप हर स्पॉन्टेनिटी के साथ एक स्टेप से दूसरे स्टेप पे जा रहे हैं. पेशेंट की हैंडलिंग आपकी बड़ी ज़बरदस्त है. जैसे आप सांस लेने का कह रहे थे तो उनका मुंह आपने उधर टर्न ही नहीं कराया. यू आर आस्किंग हिम टू ब्रीथ एंड his face is just towards your face. That's a basic rule. Whenever you ask your patient to inspire or expire, थोड़ा सा चेहरा उधर करेंगे बस. Say that. ये छोटी छोटी चीज़ें नज़र आती हैं कि आपने लॉजिकल तरीके से कितना एग्जामिन अपने पेशेंट्स को किया है. आज आप घबराए हुए नहीं, क्योंकि अगर मैं 100, 200, 1000 मरीज एक सीक्वेंस से एग्जामिन किए होंगे, that will be your second nature. So these small things tells us that you have examined patients with a proper logics and sequence. That's very important. So today we'll just keep these 2-3 things. Try to make yourself habitual of presenting your findings to each other.
Yes.
Simulated environment like that of exam. इसको मैं फिर next time और भी कुछ करूँगा.
Thank you, sir.
ठीक.